This is the final presentation in the introductory series on the topic of musculoskeletal radiography. The intent of this presentation is to provide a description and give examples of pertinent osseous alterations that you may encounter during radiography in your veterinary patients. By the end of the presentation, you should be able to identify and describe the patterns of lysis and patterns of periosteal reactions, and most importantly, you should be able to distinguish between non-aggressive and aggressive lesions and start considering some differentials. Bone response is limited to lysis and proliferation. And additionally, you need at least 30 to 50% change in the actual mineral content to identify the change radiographically. So for lysis or destructive changes, that usually means that we need 5 to 7 days after the process has started to be able to identify it on a radiograph. And for productive or proliferative changes, it typically requires at least 10 to 14 days after the process has begun for us to identify it on a radiograph. Unfortunately, there are also many more disorders than the type of responses. So different disorders can have similar radiographic appearances, and lesions typically distinguished by a constellation of findings may have an atypical appearance on radiographs. Finally, the radiographic alteration may lag behind clinical lameness in some disorders, such as with osteomyelitis, or may actually precede the clinical signs of lameness, for example, oftentimes in malignant bone tumors. So radiographs are going to be fairly nonspecific and may or may not have changes at the time that our patient presents. Let's start out talking about lysis. And early bone loss can cause subtle alteration to the bone texture, and then the ratio of volume of bone destroyed to the opacity of the adjacent uninvolved bone is really what's going to be important for us to be able to appreciate on our radiograph. A destructive focus, especially early on, is going to be more apparent in our cortical bone than it is in the cancellous bone. We're going to talk about our localized bone loss, classifying it as the different patterns of lysis that are listed here on the slide. And we're going to go through each of these one at a time. So the first pattern of lysis we're going to talk about is geographic lysis. And geographic lysis is a relatively large, often well-defined regional area of bone loss. Oftentimes this can be due to a non-aggressive process, but we will look at some other things that we can use to determine a non-aggressive process from aggressive. So in this first example on the left of our slide, this is an open mouth ventrodorsal view of a maxilla of a dog, and we can see that there is this large, relatively oval region of lysis or lucency. This would be referred to as geographic lysis. This lysis has very sharply defined margins, and this is due to a non-aggressive process, which is a dentigerous cyst. In this proximal humerus of this dog, there is another region of kind of focal lucency, which is a geographic area of lysis. However, if we look at the margins, they are much less defined, and this is actually due to an aggressive process, which in this region happens to be a primary bone tumor. Here's an example of a stifle of a horse, which also has a defined, well-defined area of lucency in this medial femoral condyle, and has a very thin sclerotic or dense area of bone rim to it. This is a non-aggressive process, a bone cyst. And in this distal ulna of this dog, this is an example of a similar process, a bone cyst in the dog, and again, a fairly uniform area of lucency that is very well defined. So this also has an expansion of the bone, but expansion does not really indicate non-aggressive versus aggressive. It's just telling us that there is some growth going on. So these are non-aggressive processes. The next form of or pattern of lysis is moth-eaten lysis. Moth-eaten lysis is multiple small to medium-sized excavation, of bone loss that tend to become more confluent. These tend to be regionally invasive and more aggressive, and almost always aggressive processes. Now, I'll take an aside here to tell you that aggressive does not mean cancer, right? Aggressive processes can be infectious processes such as fungal infections as well as neoplastic processes. On the left of our slide is a metacarpus in a dog that has examples of these kind of small to medium-sized excavations of bone loss in both the distal second metacarpal and also in the proximal fifth metacarpal. Again, sometimes these become more confluent and can even have areas that almost look geographic as well. And this happens to be fungal infection. In the image on the right, this is a distal radius of a dog that has moth-eaten lysis, multiple small to medium-sized excavations of bone loss, maybe even a little bit more geographic here. So sometimes we'll see mixed patterns of lysis, which is from a primary bone tumor or osteosarcoma, so a very aggressive process. Here are two more examples. This is the proximal radius of a dog that also has moth-eaten lysis, that has small and medium-sized excavations of bone loss. Also some expansion of this, indicating a growth rate going on, and this happens to be osteosarcoma. Here is a proximal humerus of a dog that has a little bit different appearing moth-eaten lysis, much smaller, and then fewer medium-sized excavations of bone loss, kind of also expanding the caudal cortex here of the proximal humerus, and this is a primary bone tumor, in this case hemangiosarcoma. Our final pattern of lysis is permeative lysis. This is the most aggressive pattern of lysis, and these are numerous tiny little slots or pinpoint areas of bone loss. They are typically pretty indistinct, and they oftentimes fade into normal bone. And again, these are this is the most aggressive pattern of lysis, and it almost always indicates a malignant process. So this is a magnified area of the distal tibia, and if you notice in this distal tibia there are multiple little slot-like or pinpoint areas of lysis, and then fairly normal looking bone that it kind of faded into. This patient also has some moth-eaten lysis as well, so again oftentimes mixed pattern of lysis, and this is a primary bone tumor or osteosarcoma. This is a patient that has permeative lysis in both the diaphysis of the radius as well as the diaphysis of the ulna, actually fairly diffusely distributed throughout those two bones. This patient also has moth-eaten, pretty severe lysis up in the proximal ulna as well, and this happens to be metastatic cancer, metastatic hemangiosarcoma. We can also see generalized decrease in bone opacity. So the patterns of lysis we were talking about were local or focal decrease in bone opacity. We're probably not going to talk about this as much in our course, but generalized decrease in bone opacity on radiographs is termed osteopenia. And osteopenia is a very generic term that encompasses a variety of causes. In our case, we will encounter osteoporosis most often, and that is when our bone is normal in composition, but the quantity of bone per unit volume is decreased. And we're going to see disuse osteopenia, but we may also have older patients that have osteoporosis of aging, and then sometimes you can have diffuse osteoporosis from excess steroid therapy or in patients with Cushing's. Another form of osteopenia is osteomalacia, and that is when the osteoid matrix is present but not sufficiently mineralized, and that can be seen in cases with hyperparathyroidism that can be primary, secondary, things like vitamin D deficiency or dietary calcium or phosphorus deficiency. So on radiographs, we can see overall decreased bone opacity. Sometimes we can see coarse trabeculation, and that's because the trabeculae of bone are the last to be affected. And then oftentimes we'll see thinning cortices as well. On the right of the slide, I have an example of a fetlock of a horse that has pretty severe disuse osteopenia because it was quite lame for a reason. Compare it to the normal fetlock in a horse that's to the very right of the slide. So if you notice the cortices of the bones that are included, specifically even the proximal sesamoids, are very thin compared to normal, and then overall the bone opacity is decreased. And then if you look, the trabeculae that are at the ends of the bones are a little bit easier to see, so that would be our coarse trabeculation. So next I want to talk about proliferation. And proliferation, or periosteal reaction, is new bone formation that is arising from the periosteum. And remember, the periosteum retains osteogenic properties. So the periosteum has two layers. There's an outer fibrous and then the inner cambion layer, and it's that cambion layer that retains osteogenic properties, and it can form new bone along small fibers and blood vessels, the Sharpie's fibers, that will go back from the periosteum when it gets, like elevated for whatever disease toward the cortex. So oftentimes it's more perpendicular. This is a healing response that occurs when that periosteum is elevated from the cortex, and that elevation can be from a variety of things, such as hemorrhage or edema or pus, granulation tissue, but can also be from neoplastic tissue, or sometimes it's simply been stripped away from trauma or during the time of surgery. Periosteal reactions are also classified, as we saw with our lytic reactions, and so we're going to use patterns of proliferation, and those patterns are listed on the slide. Now, I wanted to also indicate that we can look at a periosteal reaction and try to think about if it is more acute or chronic. And so duration can be the opacity that we see. So very young periosteal reactions will be very faint and very difficult to distinguish from soft tissue, whereas older or more chronic reactions will be more dense and bone-like. We can also try to think about if the disorder is active based on what the periosteal reaction looks like. Inactive reactions are very distinct with their margins, whereas an active reaction may have a more indistinct or fuzzy appearance on radiographs. Let's first look at our solid periosteal reaction, which is very uniform and continuous proliferation. However, it can be thick or thin, it can be straight or undulating, but it is usually considered a non-aggressive reaction and typically seen in non-aggressive processes. In this anabrachium of this young dog, I can see this kind of solid periosteal reaction that is on the outer part of the cortex, so periosteal, that is around the diaphysis of this ulna, which was a fracture. And so this is a callus that is forming around that fracture. In this proximal anabrachium of this dog, when we look at the cortex caudally here on the ulna, I can see this solid, smooth periosteal reaction that is quite dense as well. And this is a dog with chronic panosteitis that has this benign appearing, non-aggressive, appearing reaction. A less common reaction that we might see is lamellar periosteal reaction. In our radiographs, this has a layered or onion skin appearance, and this proliferation appears like this, occurring secondary to like a cyclic or intermittent elevation of the periosteum. It's considered a semi-aggressive reaction. It is still oftentimes found in non-aggressive processes like infection, but it is sometimes seen in neoplasia. This is a distal femur of a dog that when you look at the cranial cortex here, you can see this periosteal reaction, very smoothly marginated, but you can see it is dense bone and then less dense bone and then dense bone in layers. So this is our lamellar periosteal reaction. This is a dog that had a non-aggressive process which was eosinophilic in nature. A more common periosteal reaction we might encounter is the palisading periosteal reaction. This is irregular, well-defined proliferation that resembles the top of a fence or defensive wall made from iron or wooden stakes. So that's where it takes its name, the palisades. And this is also considered a semi-aggressive reaction, but it is most often found in non-aggressive processes. So this is a mandible of a young dog, and if you look at this undulating surface here of this fairly dense periosteal reaction that's not quite as solid as the last one, this is a fairly typical appearance of a palisading periosteal reaction, and this is a disease known as craniomandibular osteopathy. This is a tarsus of a dog, which also shows this palisading kind of irregular surface here, not quite a solid reaction along the calcaneus, and this is again a palisading periosteal reaction, which is seen in a non-aggressive process called hypertrophic osteopathy. Our next classification is the spiculated periosteal reaction, and this on a radiograph has short, thick, or long, thin spicules of proliferation, which are typically oriented perpendicular to the cortex, but they can also look more radiant or sunburst in appearance. And this reaction is considered an aggressive reaction, and it is usually found in aggressive processes. And that might be fungal osteomyelitis or neoplasia. Here is a radiograph of a proximal humerus, and this patient has kind of these short, thick spicules of bone that are oriented perpendicular to the cortex, and this is a spiculated periosteal reaction in a patient that has osteosarcoma. This is a distal tibia of a patient that has longer, thin spicules of bone that are oriented perpendicular, almost in a radiant or sunburst appearance in this patient, and this is again a spiculated periosteal reaction. Both of these patients also have different types of lysis as well. So this spiculated periosteal reaction is caused by the periosteum being elevated from the cortex faster than our bone can fill in. Oftentimes there is presence of pus or granulomatous tissue or tumor cells that prevent filling in between those spicules, and so that's why we get that appearance. Our final pattern of periosteal reaction is the amorphous periosteal reaction, and this is our least organized of all periosteal reactions and radiographically appears as clumps, clouds, or wispy strands of proliferation, and this occurs due to a disease process that is expanding very rapidly, is considered our most aggressive reaction, and is almost always seen with malignant neoplasia. In this distal radius of this patient to the left of the slide, this is kind of this cloud or clump-like amorphous periosteal reaction, and this is a patient with an osteosarcoma. In this distal femur of another dog, there is kind of wispy strands of new bone. Some of it may actually look spiculated, but there are other clouds of new bone here, and so in general, this is an amorphous periosteal reaction. But as with patterns of lysis, we may see mixed patterns of periosteal reaction. And then obviously, a lot of these disorders are going to have both patterns of lysis and patterns of periosteal reaction. So when we start thinking about developing differential lists for these different appearing lytic patterns and periosteal patterns, we should consider several factors as well. So one factor to consider is the location of the lesion. Second factor to consider is number of sites involved. And then we need to start thinking about, is this lesion aggressive? And we're going to consider the pattern of lysis, and if there's cortical lysis, the pattern of periosteal reaction. We're also going to look at something called the transition zone, and then if we have more than one time point, we might be able to also look at the rate of change. So let's talk about these varying components to help us when we're developing our differential list. probably least commonly, we might find a generalized location of abnormalities. And typically, if we see generalized lesions, so throughout the body, these are usually due to nutritional, metabolic, or hormonal disorders, and so more often a non-aggressive process. So this is an abdomen of a young patient that has nutritional secondary hyperparathyroidism, and in typical, when we look at this patient, we just see that all of these bones have very uniform decrease in bone opacity. So this is an osteopenia caused by this process. In the patient on the right here, this is a skull of a middle-aged older patient who actually has severe renal failure. And so this patient has very poor bone quality, very diffuse loss of bone, especially of the maxilla and mandible, where we barely see any bone. It just looks like the teeth are kind of floating. And this is a patient that has renal secondary hyperparathyroidism. The next thing that we'll talk more commonly about is location caused by focal or multifocal lesions. And when we see focal lesions, these are affecting one site or maybe more than one site. They can be due to both non-aggressive or aggressive processes. In the first case, we have one lesion in the distal ulna in this patient. That was our bone cyst we saw before. So geographic lysis with good margins, and this is a bone cyst. This is a patient that also has a focal lesion in one site identified in the proximal humerus, but this patient has moth-eaten lysis and some other things that will make us think of an aggressive process. So this is primary bone tumor. So focal lesions can be either non-aggressive or aggressive. Multifocal lesions will affect more than one site and as well can still be due to either non-aggressive or aggressive processes. However, in these two patients, they're a little bit more aggressive processes. So this is a metatarsus and digits of a dog, and in this patient we see periosteal reaction on a middle phalanx and a proximal phalanx as well as a metatarsal bone, and complete lysis of the distal phalanx. This is a patient that has fungal osteomyelitis affecting multifocal sites. This is a patient that on the pelvic radiographs, there are multifocal sites of moth-eaten lysis in the ilium, the ischium, around the acetabulum, distal femur, proximal tibia, as well as proximal tibia on the other leg. And this is a patient that has lymphoma affecting multiple sites. When we use location, we also want to consider the location within the bone to help us with some differentials. This is a skeletally mature patient, and I just want to remind you, thinking about the diaphysis, we have a proximal and a distal metaphysis. If we were skeletally immature, we would have open growth plates, which would be our proximal or distal physis, and then we have our proximal and distal epiphysis. So this is a pretty generic list of some differentials, but what I want you to notice is that location can help us. So when we're looking at the metaphysis of a bone, that's pretty much the only location where a primary bone tumor in most bones likes to be. Whereas if we are thinking about metastatic tumor, they affect diaphysis and metaphysis pretty equally. Fungal infection will affect pretty much all of those locations, and then bacterial infection will affect all of those locations, and particularly in the juvenile patient likes to affect the physis. So again, this is a table for generalities, but you can use it as you're working through other disorders we talk about. Number of sites can be very helpful as well. And when I say number of sites, one site throughout the entire skeleton, which we refer to as a monostotic lesion, or many sites that might be found throughout the skeleton, we'll refer to those as polyostotic. And please notice that primary bone tumors only affect one site. So one site only. If you see more than one site, primary bone tumor won't be on our differential list. All of the other things, metastatic or soft tissue tumors and different kinds of infections, can affect one or more sites, although they oftentimes, when they're metastatic or infectious, like to affect more than one site. Let's talk next about aggressiveness of a lesion. And we're going to start out thinking about our pattern of lysis. And when we look at those 3 patterns of lysis, and again, this table you can refer to later, geographic lysis is very commonly a non-aggressive process. When we get into moth-eaten and permeative lysis, that is going to be more often an aggressive process. Remember, though, that aggressive is not necessarily cancer. Fungal infections and cancers are referred to as aggressive processes in our bone. If you see cortical lysis, regardless of the pattern of lysis, that typically tells us it's an aggressive process. We also can use our pattern of periosteal reaction to help us with aggressiveness of a lesion. When we look at that solid periosteal reaction, that is almost always non-aggressive. The lamellar and palisading we classified as a semi-aggressive pattern, and then our spiculated and amorphous, we should always consider those aggressive patterns. And again, aggressive can be both, things like infection, fungal infection, and tumor. Then I said that we could consider the transition zone. The transition zone is the distinctness of the boundary between our normal bone and the lesion. In this example of this horse, this was an area of geographic lysis that has a very distinct boundary between normal and abnormal. So this is a distinct transition zone, sometimes referred to as a short zone of transition. And this typically is a non-aggressive process, in this case, a bone cyst. When we look at the humerus over here to the right of the slide in this dog, this process that has moth-eaten lysis and kind of some palisading, maybe spiculated periosteal reaction, has an indistinct transition between normal. So it takes a while for the normal to start to transition into the most abnormal. So this is an indistinct transition. In this case, this is an osteosarcoma. This is sometimes referred to as a long zone of transition as well. So this is referred to as an indistinct transition and a more aggressive process. If you have more than one time point, you can consider the rate of change over time as aggressiveness too. So less aggressive or non-aggressive lesions are going to change very little or not at all over time, whereas our more aggressive lesions may change dramatically over time. And again, keep in mind that this isn't necessarily due to a tumor. So the example to the left of the slide is a dog with fungal osteomyelitis. And on the initial study, there is soft tissue swelling, but really nothing else specifically identified. But 10 days later, very much change with even more soft tissue swelling and also now lysis involving many of the tarsal bones. So this is fungal infection. Here's a patient that presented initially with a distal radius that has a somewhat indistinct transition boundary for geographic lysis in this distal radius. If you're not exactly sure if this is very aggressive or not, it's not wrong to wait and bring the patient back. So 4 weeks later, the patient came back and now the lysis has progressed. It's now more moth-eaten and even less of a distinct boundary. And so this is osteosarcoma. So I do want you to pay attention to trying to distinguish between non-aggressive and aggressive lesions, and this is very important. Generally, when we're looking at non-aggressive lesions, we can consider the following findings as being non-aggressive. So geographic lysis, no cortical lysis, sometimes cortical thinning, but no lysis, a solid periosteal reaction, and a very distinct transition zone. The findings we would see on radiographs that are generally considered aggressive include moth-eaten and permeative lysis, presence of actual cortical lysis, spiculated or amorphous periosteal reaction, and an indistinct zone of transition. Now, unfortunately, most lesions are going to have a mixed pattern of lysis and periosteal reactions. And so when we look at these mixed patterns, we need to remember to classify the aggressiveness of the lesion based upon the most aggressive findings. So for example, if we find a lesion that has a distinct transition zone, which is benign or non-aggressive, I'll use that term instead, a solid periosteal reaction, which is a non-aggressive periosteal reaction, but has permeative lysis, which is an aggressive pattern of lysis, then we need to classify that as an aggressive lesion. So let's look at this example. This is a distal femur of a dog. And so when I look at this patient, I see areas of moth-eaten lysis. Also notice there is true lysis of the cranial cortex here as well, so cortical lysis. There is a solid periosteal reaction, but there is also an indistinct zone of transition where we have normal bone, maybe even a little bit of permeative lysis into this geographic area of lysis. On this radiograph, we can kind of see the same thing. We also see that this bone is enlarged or expanded. So even though the periosteal reaction is non-aggressive, the lysis, the pattern of lysis and the cortical lysis and the indistinct zone of transition is an aggressive process going on. And so in this patient, my differentials should include primary bone tumor, which would be like an osteosarcoma, but potentially fungal osteomyelitis. Here's an example of a patient where we're looking at the kind of distal, mid through distal anabrachium here. And when I look at this patient in this kind of distal diaphysis of the radius and the ulna, so two lesions, so the previous one was monostotic, but this is polyostotic, I see that there is kind of coarse trabeculation and maybe in the radius here some geographic lysis, but lucent area. However, the coarse trabeculation, there's no cortical lysis. It's affecting two bones in the same area. There is some very solid periosteal reaction and a very kind of distinct transition zone. Normal bone into the lesion, back into normal bone. So all of these findings that I've described are very non-aggressive in appearance. And we have not only that, non-aggressive appearance, two bones, same kind of area. There's also a little bit of distortion in the shape of these bones. This is very consistent with a healed fracture of the radius and the ulna, so a non-aggressive lesion. If you wish to explore the topic more or see more examples, then I want to refer you to the listed reading.